Hello, good afternoon. Let me introduce myself. I am Dr. Raul Oliveira, a neurosurgeon, chief of neurosurgery at Florida Hospital Suffolk Hills, and director of the Primary Stroke Center. I invite you guys to come to my office today, in which we're going to discuss a couple of subjects that are very important for our community. I just wanted to give a little introduction so you will know who we are and what are we doing here. In Suffolk Hills. We are part of the University of South Florida Neurosurgery Department, and I'm an assistant professor on a department that is more than 15 neurosurgeons strong, the biggest department of neurosurgery in the whole Central Florida. So we are embarked in a partnership with Florida hospitals in order to not only bring the patients to the neurosurgeon, but to bring the neurosurgeon to the patient. We want to have the luxury on this community of having 21st century, top of the line technology, expertise, and medical decision making, so our patients can enjoy all the benefits of having a tertiary service in their primary setting. We are delighted to be in the community. I think that we have had a great feedback from all of you in the Suffolk Hill area. We have also encountered great support from the hospital administration and from the hospital personnel in lifting this off the ground and trying to reach each and every one of you with our expertise in neurosurgical problems. So what is it that we do here in Suffolk Hills? We came here as part of the Stroke Center because in the 21st century, as you know, brain is time is brain. Brain is important. You don't want to lose brain when you have a stroke, so we have to implement the therapies as soon as possible. Strokes can get complicated. Sometimes they can be hemorrhagic, sometimes they can be ischemic, but they can have a lot of swelling. They can be caused by malformations, can be many other etiologies, meaning many other causes. And sometimes you need a neurosurgeon backup in order to operate on a patient that has a stroke that's complicated. Neurosurgery came to Suffolk Hills as part of that program for the community, but as neurosurgeons that we are, we don't only treat diseases of the brain, but also diseases of the spine, diseases of the peripheral nerves, and that's why the scope of our practice has brought in so much in the community. Initially, you can see in the picture, we came to try to help with the stroke program here. We started then doing brain tumors, we started doing brain trauma, we started doing degenerative spine disease, we started encountering all sorts of diseases that are also treatable under the neurosurgical scope. Why the spine is so important? Well, as you might know or not, low back pain and spine diseases are the first disability cause of disability in the United States, and they're one of the most expensive problems to treat all over the country. It's basically 75 to 80% of all the cases that we do are spine related. And it's basically the price that we all have to pay for getting older as a society, and also because we have to walk around in two legs. That biomechanically is a burden for our spine that over the years sustains a lot of wear and tear, especially the lower back, because has to sustain all the body of the body weight above it. It's very common for me to see patients that say, well, I have neck pain, I have back pain, I don't have any problems with my mid-back. And I said, well, the problem is that your mid-back doesn't really move because it's, encased with a rib cage and your sternum, so they're very immobile. Most of the movement of your spine occurs on your cervical and lumbar areas. That if you see the models here, cervical spine and lumbar spine. And why do we have models of the lumbar spine and the cervical spine? Precisely because they are the ones that are mostly injured, and they're injured because they have to move. That increases the degeneration, increases the repair intent of the body, and that repair sometimes is not perfect. Then again, also, as when we touch something about sport injury, those are the areas that are usually damaged when you suffer an injury or when you suffer a trauma due to an accident. Why? Because those are the mobile areas of the spine. There are many mechanisms that we can touch on later, but that's basically the basis. Our primary stroke center in our neurosurgery program in Cepheid Hills is totally capable of tackling any kind of neurological emergencies that will range from not only stroke, brain tumors, or traumatic injuries of the skull, traumatic injuries of the spine. We can also treat hydrocephalus, spinal cord tumors, any vascular malformations, including aneurysms or AVMs, and then of course all the degenerative diseases like spondylosis of the cervical and lumbar spine, deformities of the cervical, thoracic, and lumbar spine, herniated disc, spinal stenosis, and all the other abnormalities. There is a lot of talk lately about the possibilities of the minimally invasive spine surgery. We're going to talk about that too, because that is something that is very important for us to know, and for the community to know that we're able and capable of doing minimally invasive spine surgery, because that diminishes a lot the trauma of spine surgery, diminishes the length of stay of the patients in the hospital, diminishes their blood loss, and increases the time of recovery of the patients. Having all those possibilities here in the community at Cepheid Hills is of great importance also, because then the families and the patients can recover faster, they can go home faster, they're in their own environment, they don't have to travel long distances. So overall, both brain and spine cases will do better when they're treated closer to home, and they can achieve full recovery. We're going to go a little bit over spinal anatomy. As you know, the spine, this is a lumbar spine with it's a sample of instrumentation that we do in the lumbar spine. The spine is a number of vertebrae that are just one on top of the other. Those vertebrae are separated by intervertebral disc. That disc is like a cushion that in between each vertebral body stays in there and allows these vertebrae to move forward, backwards, to the sides, and also to rotate. All the joints in the back also play a tremendous role in this movement. It's very important to understand that the movement of the spine as a whole is not achieved by one or two segments alone. It's a compounded, it's the summatory of all those little movements that can give you the full range of motions. That is why when you have one or two segments that are diseased and they need to be fused, you don't realize that you lose that much range of motion, because the rest of the segments pick up the slack from the one or two or three segments that are fused, and then they move. Overall, you don't notice a difference. Of course, if you fuse every segment, you're not going to move your spine, and sometimes that happens too. It depends on the gravity or the extension of the disease. Patients that have kyphoscoliosis, or they have kyphosis and all big deformities in their spine, or big trauma on their spines, they sometimes need to be fused many levels, and that obviously has an impact on their ability to move. If it's on the neck, on their cervical spine, also depending on what level you have that problem, it might impair your ability to rotate your head or look up and down, and that of course has consequences when it comes to like driving or having your normal life, because you have to move as a whole. You cannot rotate just your head on top of your neck. We do that. That happens especially when you have occipital cervical fusions, and a lot of patients that have bad rheumatoid arthritis, that tends to affect the upper levels of the cervical spine. And Sometimes they need to be fused the head to the upper levels of the cervical spine, and then that movement is impaired. As you can tell from here, in between each vertebrae, right behind the disc, I'm going to show you another model in which you can see that even better. And when you see the whole spine here, you understand how your hips receive all the load from the rest of the body, and especially here between the fifth lumbar vertebrae and your sacrum. This is the joint that usually suffers the most because it's sustaining the weight of all the other ones. It's the biggest and stronger one too. Then the other ones become smaller because they don't have to carry that much weight. And as you can tell, the ones here at the base of the skull are the ones that I was telling you are very important for the rotation of the head. In between each vertebrae, this yellow little thing here is the spinal nerves. The nerves come out of the spinal cord that runs through the canal inside of each vertebrae. The spinal cord usually ends at around T12L1 when the thoracic vertebrae end and your lumbar vertebrae start. From here down, there's no more spinal cord in that canal. There's only nerves hanging. That's called a cauda equina, which is Latin for horse's tail. And that cauda equina is this multitude of nerves that are just floating in fluid. And when the first anatomy started to dissect cadavers and they opened them up to look what was inside, they look at all those nerves and they reminded them of a horse's tail. And that's how they called it cauda equina back in the Roman times. So that and that's very important, because when you have a cauda equina syndrome, that's a neurosurgical emergency. That means that you're compressing all those nerves, and those nerves all go from your belly down, so you might not be able to move your legs, you might not be able to control your bladder or bowel, and you need to decompress those nerves emergently so you can recover that function, because the longer they're compressed, the harder it's going to be for them to gain that function back. So as you can tell in this model that I have here, sometimes that disc that goes in between the two vertebrae kind of like pops out like that, meaning that herniates out of that annulus, the fibrous annulus that it's encasing around it and keeping it inside between the two vertebrae. Sometimes that annulus breaks because it gets old, it gets friable, it desiccates, or because you overexert or did something that you shouldn't have done in a certain position, or you have an accident, or like a patient we had here in Suffolk, was actually the first patient that we operated here that was skydiving and landed the wrong way, and then the disc herniated and compressed this nerve acutely, came in horrendous pain to the ER. We operated him with minimally invasive surgery, which I can even show you pictures of the incision, which is like 1 inch long, and the next day he was ready to go back and jump again, which I told him no. But it's a testament to how successful these procedures can be when you do it right away. Now, when we're talking about chronic back pain is a degenerative disease. Well, you can have chronic back pain for many reasons. It's an entity, it's a syndrome, meaning it can have many causes. I always tell my patients, the fact that you come to me with back pain doesn't mean that you need surgery. Not all the back pains need surgery, because the causes can be very different. It's like when you come to my clinic with headaches. You can have headache because you have a migraine, you can have headaches because you have hydrocephalus, you can have headache because of your sinuses, or you have meningitis, or you have high blood pressure, or you have a brain tumor. So it all depends on what is it that is causing that symptom, that the treatment that you're going to receive. In the case of low back pain and chronic back pain, that's why we have to study the patient. We don't operate on a patient just because the scan is abnormal or just because the patient has a symptom. We have to diagnose the disease and determine if that disease actually needs surgery or not. Um, the majority of the back pain, chronic back pain, is, as I said before, wear and tear. It's called spondylosis. It's called osteoarthritis. Is because your discs, as we get older, our discs shrink, they desiccate, dehydrate. Then you end up with bone rubbing on bone. All that calcifies. Then you get osteophytes, and that can hurt. Now, you can have arthritis and your joints can hurt, or you can have chronic back pain because you had an injury when you were younger, or you had a car accident and you injured one of your vertebrae, you have a fracture that never healed, or you have some genetic predisposition to this, or some congenital defects on your vertebrae. And all those things are going to have influence on what kind of treatment you are going to get. Common conditions on the spine. You have what we call spondylolisthesis. That's when your vertebrae kind of slip one on top of each other, and that can cause a lot of pain because the spine is misaligned and the spine is now not distributing the charges the way they should. So that vertebrae is trying to get away and is pulling everything with it, and everything hurts. It's very common, this, as part of not only degeneration in older people, but you can see it in younger people, especially on patients that were athletes and their teenagers, especially gymnasts or other highly demanding sports, and that have obviously overused their joints. There's a condition called spondylolysis, in which you were born with a defect on your facets and they're not completely joined. So there's a separation there. That, when you overexert them, predisposes to this condition too. In these cases, you have to be very sure of what is it that you're treating, because if you do have one of those slipping vertebrae caused by a defect, this is not going to get better with anything except for surgery. But if you have degenerative disease because your spine is getting old and your discs are degenerated, then probably you're going to get better with non-surgical treatment. Probably you're going to get better with pain management or physical therapy or other conservative methods that do not include surgery, because in reality, as I explained to my patients, the majority of low back pain, chronic low back pain, doesn't require surgery. And if you do surgery on those, the back pain is not going to get better. So those are the patients that you hear, going around there. Well, I had 3 back pain surgeries, and my pain never went away. It always came back. So I don't really know what to do. Would you please operate on me so the pain's going to go away? Well, no, it's not going to get away, because the more you operate, the more pain you're going to have, and your pain is not going to go away because the surgery is showing you that the surgery is not the option. And of course, every patient's different. This is just it's a generalization, but that's why medicine is something that is not only science, but there's a little bit of experience, a little bit of art. Every patient's different. We treat patients, we don't treat diseases. You can have the same disease, but be a completely different patient, and one thing is going to work for you, one thing is going to work for the other. That's why it's very important to have a good communication with your doctor and go to the right doctor. If you don't know, you should always start with your primary care physician. Your primary care physician is the center of the health system. They know you better, they know what your problems are, and they can diagnose if you have a condition, and they know who they should send you to. Okay, so if you have chronic back pain and there's nothing in your imaging or your physical exam that it's surgically fixable or repairable, then you should probably pursue a pain management treatment or consultation, or sometimes you should pursue a neurologist in order to see if your nerves or your legs are hurting because you have a problem with your nerves, because you have an intoxication, because you have a neuropathy, because of the nutritional deficiency, many other things that are not surgery related. Now, if they determine that you have a herniated disc or you have some of these problems that need surgery to be fixed, then you should come see a neurosurgeon. So it's a process. Just the fact that you have headaches doesn't mean that you need to have surgery on your brain. Just the fact that you have back pain doesn't mean that you need to have back surgery. The same with neck. Usually we treat the patients that have pain that radiate to the extremities. That means that there's an abnormality there. There's a structural problem that is compressing on the nerves, and those nerves are giving you the symptoms that radiate. In those cases, we want to free those nerves up. In cases that your spinal cord is compressed, we want to release your spinal cord or your cauda equina. Remember the cauda equina? So we have to decompress those. But if your pain is just in your neck, just in your back, and is related to degenerative arthritis, is related to stenosis that is not really creating problem with your activities of daily living or impairing the way you function every day in life or society, then you might not need a surgeon. Actually, the surgeon can actually make you feel worse. We have also that conundrum of our population that is getting older over time, which I think is a very good thing, because of course that speaks about the level of healthcare, the level of nutrition and preventive medicine that we have in our society these days. But as you get older, then everything gets more complicated, because then your bones, especially females or postmenopausal, your bone starts to get more friable, they get brittle, the calcium gets away from them, then you go into what we call osteoporosis, and you tend to have more fractures, and then you tend to have compression fractures because your bones are not strong enough to withstand what we call axial loading, or when you have flexion injuries. Sometimes you just fall on your buttocks and then you compress your vertebrae. And that can be very, very painful because it's a broken bone, and that might need or not need surgery. Sometimes all you need is a brace for comfort, and you'll get better once this bone heals in place because it's not deformed. Sometimes you need to have that bone that is crushed elevated, and we can achieve that with kyphoplasties or vertebroplasties. And sometimes, unfortunately, it's so much and it doesn't get better with any other things, or there is a fragment of that bone that is being pushed back and pressing on the nerves or the spinal cord. At that point, then you're going to need surgery, sometimes smaller surgery, sometimes even bigger surgery, in which we have to replace the whole vertebral body and put a metal cage or some implants there to try to reconstruct the spine. So very important for the population to understand that the majority of back pain, even those that are related to sport injuries or those that are related to degeneration, chronic spondylosis and aging, they do not need surgery. They need to be filtered. They need to undergo conservative management, which will include, again, pain, physical therapy, medication, sometimes chiropractic manipulation. Sometimes all you need is a brace. Sometimes all you need is behavior modification, because we all know that as we get older and healthier, we're also getting fatter. So obese patients, obesity, it's a problem. It's a problem for your joints. It's a problem for your ankles, your knees, your hips. It's a problem, let alone all the other risks that comes with obesity, from sleep apnea to having increased cholesterol in your blood and high blood pressure and diabetes and the risks for heart attack or stroke. But also it increases the load your spine has to carry around. So as your other joints suffer, your joints on your spine will suffer too, and then you will have more problems. So behavior modification is one of the key components of taking care of your health problems. It's one of the most difficult, though. Patients, we know, from med school, they always tell us that, the most difficult thing to change on a patient's management is their behavior. We like to do what we like to do, and it's hard to stop smoking, it's hard to stop eating, it's hard to start exercising. But it's a key component. It's very important. I cannot really reinforce that enough, because that will spare a lot of problems. And not only creates problem in your body and creates conditions that need surgery, but also makes your surgery even more difficult. So, because then increases the risks of intraoperative complication, increases the length of the surgery, the depth of the surgery, the blood loss, increases the time of your recuperation, because it's not easy to get you out of bed and get you back to moving. So all those things we have to take into account. So what are the couple of the things that we can do for sports injuries or chronic back pain conditions, depending on the cause, of course. When you have compression of your nerves, we usually either have to identify what's the nerve that's compressed and identify what's the problem that's compressing the nerve. If it is a disc, then we have to do a discectomy. We can do a discectomy open, like a traditional method, in which we just do a laminectomy, taking the back of the vertebrae off, making room for all those nerves or the spinal cord, and then opening up those foramens. That's called foraminotomy. We can do that also in a very minimally invasive fashion with a tube that will go through the skin. You can see in this picture, you can see a picture of the old approach and the new technology. And in those cases, we just go right exactly on top of where the problem is, and we can decompress that nerve, and we can make that better. Sometimes you do have to decompress everything, because it's not a stenosis on one nerve, it's stenosis on all your spine. So in those cases, surgery sometimes is a little more extensive. So it depends on what it is. And sometimes if you have abnormal movement on your vertebrae, then you need fusion. Fusion is achieved with internal fixation. This is one of the devices that we use. This is other devices that we use for the neck. We can, in the neck or the back, we can do this from the front. We can do it from the back. This we can do from the back, from the front, from the side. The thoracic, it's a little more complicated, but we can also do it. So why do we do that? Because then we need to immobilize those vertebrae, and we need to put spacers in between them, and we put allograft or substances in there that can promote the growth of bone, and we create a bony bridge between the two vertebral bodies, or in the back of the vertebrae, so they don't move again. So again, your health and your condition will determine a lot of the success of the surgery. A patient that has poor bone because of osteoporosis and is malnourished, or patients that smoke, will decrease their rate of fusion tremendously. Smoking only decreases the rate of fusion more than 20%, from like 98% to roughly 80%, just because your blood is not carrying enough oxygen to have this bone grow in the area that we need it. This is a sample of how the minimally invasive tubes work. Instead of opening the skin and separating all the muscles, we just go right on top of where the problem is, and then do what we need to do. These are different techniques. The pictures in the computer can show you, all the variants that I talked to you before, from the back, from the front, from the side. And the important thing, and I want to emphasize, is basically that your spine is a very complex organ. Your spine, it's every level is different, every patient is different, every injury is different. So you need to look for your physician, look for a specialized doctor, and then have an open conversation with them and try to find what's the best solution for you, not just for the pain or the condition, but for you, because it might work, something might work for you that is not good for another patient with exactly the same disease or the same symptoms. Again, thank you very much for listening to me. I think and I hope that in general I was able to clarify a lot of the issues regarding back pain, or how to approach it, where to go and look for help, and the different ways that we can help you in the different conditions that you might have with your spine. I hope I see you around, and if you have a problem, here we are to help you. Thank you. Okay, so when it comes to the conservative management of spine conditions, there are two major aspects of it. Basically, either you go to pain management, which is a very specialized service, or very specialized doctors that will really go to the bottom of what your condition is, and at that point they will make up a plan of what's best for you. It could be only medication, it could be a combination of medications. Some patients do not need narcotic medications, some patients do need it. It's very important that the doctor that manages your pain medications is a specialist in that area, because those medications are very dangerous, they're very strong, and they can also interact with other medications that you take, and they can give you a lot of side effects. The doctors specialize in pain medicine. They can also give you specific injections in certain points, sometimes with pain medication, sometimes with steroids, which is an anti-inflammatory drug, and those may serve different purposes depending on what your condition is. Some doctors also do spinal cord stimulation, which is a step above, in which you have electrodes implanted like directly on your spinal cord, and they can also have a very good result on you. But again, patient selection is very important, because if we choose the wrong treatment for you, it's not going to work for you. And sometimes even if it's the right choice, it doesn't work, and then you have to try something different. Unfortunately, in medicine, sometimes it's trial and error that guide us towards what is that's going to work for you. You should not start trying to kill an ant with a cannon. You have to step by step trying to find out what is adequate for that patient. When it comes to physical therapy, which is the other branch of conservative management, it's very important to tailor your therapy specifically to what your needs are. Okay, so if you're a patient that came and you have a disc herniation and you couldn't move your leg, then you're going to need rehabilitation for that leg specifically, how to move it, your muscles strengthening, etc. If you had problems with your cauda equina and then you ended up with a deficit in the control of your bowel, your bladder, then you're going to need to learn how to control those. You need to probably see a urologist and have other specialized treatments along with it. If you had a fracture, then you need to heal that fracture, and your therapy is going to be tailored towards reconditioning your body as a whole. But obviously, you cannot move a fracture, because if you move a fracture, it's never going to heal. Majority of the patients I see with chronic back pain and degenerative disease in the spine, I try to tell them to avoid exercises or sports that are violent or that implicate impact. Obviously, every time that you jump or jog or parachute or skydive, or you're on a boat, or you're on an ATV on a rough terrain, or you're riding a horse, or wrestling an alligator, you have to be careful, because those it's like when you have a head injury. You should not be boxing, you should not be doing football, or doing things that can re-injure your brain. The same thing goes with the spine. So that is what I usually tell my patients. You should go to the physical therapy department, which we have a great department at Florida Hospital Stuffy Hills, a wellness division there. It's a wide array of different treatment options that they can do for the patients. They're very specialized, and they should assess you and establish what your needs are, depending on, of course, the doctor's recommendation. This patient had a fracture, has a fusion, the patient just had a herniated disc, he just needs reconditioning, or this patient really needs therapy to regain certain functions. All stretching exercises, flexibility exercises are okay, but it has to be done depending on what your problem is. So I think for every aspect of the treatment of spine conditions, every part of the team has a role to play, and they need to communicate at the same time to find what's specific for you and your condition. Thank you.